So welcome everybody. This is the last of six lectures on topics related to healthy aging by Dr. Paul Spector. So I'm just going to let him introduce himself and the topic. I'm going to tell you that we have refreshments afterwards. Paul tells me this talk's a little shorter than some of the others, so please do feel free to ask questions. Just stick around afterwards. We're not going to kick anybody out. And I'll turn it over to Paul.
Okay, thanks, Tammy. Welcome, everybody. Today is the last one, so I'm going to make it, a lot shorter than the full hour, so we can talk about ideas you might have for topics that we could cover, or just ask me anything kind of thing, and spend some time doing that. I'm going to be talking about health literacy first, and that's really basically trying to inform yourself about what's going on out there. I don't think it's ever been more important because there's so many options, and so much new stuff going on. I also think it's never been more difficult to sort, the false information, advertising, exaggerated claims, identifying the source. It's really not easy. And if you want to be informed, it requires a certain amount of work. And I think it's worth doing, though, because we are living in a time where I think, you are the most important person on your medical team. We used to have this sort of passive relationship that was encouraged definitely by the medical community. And I think it was also created to a certain extent because of the pharmacology revolution. And there was just all of this medication that started being, antibiotics and stuff. And so people had this sense that, you go, you take something or are given something or have a surgery. And now most of the problems in health are from lifestyle. And so that's harder to learn about also because, sometimes the people who are controlling that industry aren't even really in the health in terms of traditional, science. They may be, proponents of different kinds of fasting and cleanses and, exercise routines. And there's good stuff in all of that, but, how you figure out which ones is what I'm going to try and help you with today. I'm going to start with a story that I think gives you a good sense of, oh, that's too bad. I don't know if there's a way to take that off the screen, but so, every 5 years, the United States, puts out these dietary guidelines. And it's something that is, all the people in the field, nutritionists, all the medical science people who are at the head of the field, participate in what they think should be the changes. And they provide huge amounts of evidence-based recommendations. And then it's kind of interesting to see which recommendations are adopted. Because they're making recommendations on the basis of, really good science. I mean, there's things we don't know, but there are things we know in this area. And so you would think that there would be a pretty direct correlation between what the experts are saying and what the recommendations are saying. And it's not. In 2015, there was a correction that started to occur that really reversed almost 40 years of certain theories about diet. And I'm going to go over two of them just to let you see how tricky it can be. Cholesterol has been something that we all know about. If there's one test, that we know, it's cholesterol. A lot of people can even tell you, their numbers or something, to HDL and LDL, and careful with the eggs and all that stuff. There has never been a well-performed study that showed that dietary cholesterol and blood cholesterol levels are significantly related. There's a small population of people who have, familial cholesterolemia, hypercholesterolemia, which is its own very specific thing. It's genetic, but that's a small population. So for the rest of us, the idea that fat in your food translates to fat in your blood, in this kind of direct way, or that cholesterol especially does that, is false. Most of the cholesterol in our blood, we make it. You know, it's a really important compound. It's in, you know, all of our hormones, and it's in cell walls and stuff. It's important, it's essential, but the dietary component is really small. There's also no connection between cardiovascular disease and cholesterol in the diet. So all of the time, literally like the last 40 years, you know, heart healthy diets have been, you know, often low fat diets, low cholesterol diets, and there's no data to support that. And if you're interested in the story, it goes back to a guy named Ansel Keys, and I'm not going to get into it because it's so, but it's a really interesting story where there was a study, they omitted, it was international, and they omitted several countries, in large part, I think, in retrospect, because the data wasn't agreeing with the theory that they were trying to create. And then there was a whole series of people who were very powerful in government, who left government and went into the regulatory and food industry, and basically responded to lobbies that were, you know, the sugar was just incredibly powerful, and much more powerful than the fat lobby, apparently, you know. And so, you know, sugar was okay, and carbohydrate, okay. Fat, dietary fat was the devil, and it's really exactly the opposite. I mean, they're bad fats, but there are a lot of good fats. But a carb is a carb is a carb. You know, a sugar is a sugar, and that's what causes most of the obesity, diabetes, cardiovascular disease, stroke. That's where the problem is. So they made this recommendation: drop cholesterol as a nutrient of concern. And they also said you should eliminate any limitation on total fat consumption. Because what had started happening was they were decreasing the amount of fat in foods. You have to replace it with something, and you have to make it tasty. And fat is incredibly satisfying. It fills you up, right? And so it was replaced by carbohydrate, and it, you know, give it a little sweetness. And we all thought that's better. Or it's just, even if you're talking about skim milk, they have to replace things to give it body and to give it mouthfeel and taste, all these things. We've known that decreasing dietary fat does not lower the incidence of these things unless you're talking about trans fat or incredible amounts of saturated fat. But if you're eating good fats, you know, and a variety of them, nuts, you know, vegetable oils, fish, you know, fatty fish, fat is really good for you. By replacing the dietary fat with carbohydrate, we were off to the races with the obesity epidemic. If you look at when it started, I mean, it's multifactorial, obviously, you know, and the amount of activity and things like that, portion size, the processing of foods, and all that is important. But really, one of the biggest things was replacing fat with carbohydrate. And people, you know, a lot of people were doing that. And you go to the supermarket, and if you look at skim milk, I mean, so many people, or yogurt, non-fat yogurt. I mean, still, this has not trickled down. I know lots of people who are, you know, perfectly intelligent, well-informed people who believe that there's no advantage to, they believe there is an advantage to eating low-fat foods and the whole light, you know. Whenever they misspell something, you know, there's something suspect. Yeah.
Isn't it also the ratio of the total cholesterol to the good cholesterol that really counts?
Yeah, well, this is another thing. The good and bad cholesterol categorization isn't exactly right. We used to think HDL, the good cholesterol, the more active you are, the higher it goes. True. And one of the reasons it was good was because it transported fat out of the blood to the liver processes. Turns out LDL does that also. The other big problem that is amazing is that the most common test that is used to measure blood cholesterol levels is not the way that you're going to find out what your risk is for cardiovascular disease. And the reason is it's like if you're going on a road trip and you want to know how much traffic there is, you don't care how many people are in the cars. You care how many cars are on the road, right? What the standard cholesterol test does is it measures a certain concentration of cholesterol in a volume of blood, all right? That doesn't tell you how many particles are there that can be going up into the vascular wall and starting to create a plaque, and kind of constrict the space and create all the diseases that are associated with cardiovascular disease, right? So there is a test, it's called an NMR lipid profile. We've had it for some time. It's probably a little bit more expensive, but it gives you a particle number so that you know. It also gives you particle number for each one of them. It gives you the size of the particles, which we thought was very important. Now it seems like it's not as important. But there's also a test, one test, and it's not expensive. It's called ApoB, lipoprotein. And ApoB will give you the same information because every atherogenic particle in your blood has this ApoB. So you find out if you get your ApoB measured, which I recommend you all do, and it's the best thing to follow, and it's just one test. It will tell you what your real risk is, whereas the standard one doesn't. Now, if you're way high, it probably is going to be a reasonable signal. But there are people who are. The other thing is, 50% of people who have heart attacks have normal cholesterol. So part of the reason is because of that. I think part of the reason that can be said is because of the test that's used.
Could you ask your doctor to do that?
Yeah. And I'm going to speak about that when we talk about choosing a doctor.
I found, this is very interesting to me because right now I'm trying to get off my statin.
Yeah.
And once they put you on it, man, they do not want to take it away.
Yeah.
It's very difficult.
Why do you want to get off?
Why do I want to get off? I think the less drugs I take, I think the better off I am. I don't like to take drugs.
Yeah. Statins are an interesting group of medications also because, they have looked at huge numbers, right? So many people take statins. So we have volumes of data. And one of the things they saw was that if you look at people who would seem to be non-responders to statins, in other words, their cholesterol didn't drop down significantly, they also seem to have a protective effect. They also have lower incidence of cardiovascular disease, stroke, diabetes. And the reason is because they're incredible anti-inflammatories. They're systemic anti-inflammatories, not in the sense of a Motrin, but in the sense of just that whole chronic low-grade inflammation is such a big part of the picture these days in the way we live and eat. So that might be one that you would consider being more comfortable with. Unless you're somebody who has side effects with them, but there are people who have like muscular aches and pains with statins. Do you?
No, I've been on it for years. But I have made a lot of dietary changes, a lot.
Yeah.
And my cholesterol level has come down. I'm actually going for, because my brother has an aortic aneurysm.
Oh.
Or actually he had a dissection.
Ooh.
Very bad. She's sending me for a cardiac scan.
Yeah.
To see if I have any plaque buildup.
Yep.
And then deciding on whether or not I do, she'll consider taking me off the statin.
But that's the other thing. Statins stabilize plaques that are already there. And that was confusing at one point because, you can get a calcium score, right? And when you're on statins, your calcium score actually gets worse in traditional, nomenclature. But the point is that's because they're stabilizing the plaques. So and the reason that's a good thing is because, when a plaque flex off, it blocks whatever's downstream. So it can get into the circulation and, happen in the brain, and that's a stroke, or it can happen in the coronary arteries and it will block the heart muscle somewhere, and that's, the heart attack. So stabilizing plaque is good.
So you're not dead set against statins?
No, I'm a bit of a fan of statins.
Okay.
Yeah, but I'm also I believe that somebody wants to see if they need a medication. Just because someone prescribed a medication for you that was appropriate 20 years ago, or 10 years ago, or 1 year ago, doesn't mean it's appropriate for you now. And you can do a slow taper. I wouldn't go off it, but I think it's very reasonable to do a slow taper and see. But you have to be working with, and we'll talk about this, choosing a doctor. You have to be working with someone who's willing to, what I think is just do good care.
Well, my son, he's in his late 40s. He was taking statin, and he noticed he would have aches. And
Yeah.
He was like, couldn't figure out what was wrong with him, and he stopped taking it on his own, and he felt so much better.
Yeah.
But I said, you shouldn't just you have to tell the doctor into it.
Yeah.
So.
There's also, was he taking, do you happen to know if he was taking coenzyme Q10 with it? Because there is an antidote for a lot of people with the muscle aches with statins, which is an over-the-counter, vitamin kind of thing.
Yeah, I do take that.
Yeah,
What is it?
Coenzyme, what are they?
coenzyme Q10.
Right, it's just
Yeah.
like a vitamin. So I take that every day.
Because that is depleted by the statin, and sometimes that can be involved in side effects. Yeah, yeah. So what these recommendations ended up translating into was, and there was never anything about sugar, if you can imagine, until 2015, and so there was so much data, and it began to come in. So they started talking about limiting sugar. And then with fat, they only spoke about trans fat and saturated fat. And they didn't get into the whole substitution of fats with carbohydrates. So that it's a work in progress, but it gives you a sense of the extent to which, you can have all the knowledge and the information, and it doesn't translate. And you would think that, the USDA and the health, that the governmental agencies would be interested in the health of the country and decreasing the medical bill. But this is the problem with money, in these things. This is one other thing that, is happening that I think is a good example of how tricky it can be. Over the past 10 years, there's been an explosion of, as you know, use of marijuana, and it's both recreationally and medically. Because it's becoming legal, there's a lot of research that's going on more than before, which is a good thing. But if you look at the online search volume for cannabis cancer cures, the incidence of it is 10 times, it's grown 10 times faster than standard treatments for cancer. And I have to say, the reason for that is because there's a huge amount of money to be made. It's not a coincidence that you see more of this kind of advertising or publication in the states where cannabis is legal. And the top false story for cannabis as a cancer cure generated 4.26 million engagements. And by engagements, they mean just either reposting, retweets, comments, a dialogue starts, that sort of thing. The top story debunking this generated 0.036 million engagements. And this is something that we're seeing a lot of in every field, right? It's not just science and medicine. I mean, fake news or real news. I mean, we have, you can have a disagreement with, a friend about what's actually happened because, you listen to different news stations. It's kind of, crazy now. And a lot of people are studying this because it's so prevalent. And what they're finding is that fake news travels faster, spreads deeper. It's like that old saying, what was it, a lie can be halfway around the world or something before the truth gets its shoes on. Isn't there some saying like that? Yeah. So false news stories are 70% more likely to be retweeted. This was a study that was done with Twitter specifically. True stories take 6 times as long to reach 1,500. And false stories spread 10 to 20 times faster than factual stories. And, there are a lot of reasons for this, but part of it is, these fake stories are made to be appealing. They're offering a cure or something, they catch your eye, and there's all of these vulnerable populations who, wow, that would be great, and, don't know how to vet the information. There's also a phenomenon where, if you're going in to look at studies, you'll see meta-analyses, they're called, right? And a lot of you know what that is, but it's, where they combine several studies so you can have a huge study population. But, you have to be very careful when you're combining studies because they have different inclusion and exclusion criteria for the people. They have different, what they're examining. You can't take the results from a study that's not looking at what was the change in blood sugar. If that's what they were looking at, you can't say, well, we also noticed that the blood pressure was, that wasn't what the study was designed to do. And that is a risk of the meta-analysis. So it made me think of this quote I remember from No Country for Old Men by Cormac McCarthy, where he says, the stories get passed on and the truth gets passed over, as the saying goes, which I reckon some take as meaning that the truth can't compete. You have to say that with a real accent, like a cowboy, but I'm not. So let's talk a little bit about the criteria for looking at a news story on a medical issue. If we're looking at where it's appearing in terms of the medium, television is probably one of the worst, and that's because it's so quick. And you can't do a quick story and really do justice to the, cost benefit, and the science. It's impossible. And that's the source for a lot of people, that and social media. Newspapers, does anybody read? Well, you read newspapers online for the most part now, right? That can be better. One of the things that you always want to look for is a link to the study that's being reported, right? And you'd be amazed at sometimes how different the study reads to the article and the headline that you've just taken in. Medical journals, are probably the best, but that's tricky too. You have to look at all sorts of things that we'll talk about there. And then there's a lot of stuff that is sort of undefinable. What is this? Is this an article? Is it an advertisement? Is this from a medical journal? I don't know. And so you want to try to see where it's coming from. And if it's a website, there should be some place where there's an about us or something like that that tells you who are these people, and funding is huge. So you want to see, is it an industry sponsored, kind of publication? So if you're looking at a medical journal or a science journal, there's a wide spectrum of types as well, right? So you want to see what the peer review process is. The good journals have peer review, and so they don't publish a paper until they get 3 or 4 guys who are at the top of that field who didn't participate in the research to look at it, critique it, send in suggestions, thumbs up or down, or you have to do this before you can publish it, that kind of thing. Not all medical journals are peer reviewed. So that's something you want to look at. The funding, as we said, is essential. Funny enough, when the sugar industry funded these studies, it seemed like it was a really safe thing. And then this is a relatively new thing, but in medical journals, the authors have to declare if there's a conflict of interest, which usually means, are they consulting for private industry? And that's happening a lot. That's one of the ways that these guys can, as a researcher, you don't make that much money. But if you're consulting for Nestle or, Nabisco or something, you can make a lot more. And so you have to be careful how you interpret their findings when they are involved that way. You also want to know, well, how new is the data? You want to remember that it's something that gets published. The work was probably done at least a year before. What's happened in that year? One of the things you can look at is the number of citations. So if it was something significant, usually you'll see a high number of citations. If it was something fallacious, you can also see there might be a high number, so you have to be a little careful there. But if it made no splash, it's probably not a big news story, The other thing is, you see this all the time, in the lay press, a headline about this agent or that agent having fantastic effect on, let's say, a disease process. And it was done on mice. Lucky, not necessarily on humans. Or it could be that it was done on cell cultures or in vitro, which means, it was a test tube situation. It wasn't in a living organism. So all of those things can be relevant and interesting and build a case for something, but there's no one-to-one correlation between something working in mice and something working in people. Sometimes it does, and sometimes it doesn't. And a lot of the things now that are related, let's say, to anti-aging, we're slowing the aging process. Most of that has been done until very recently on, either lab animals who have short lifespans, sometimes microscopic, animals, because you can have 25 generations in 2 days. So you can really start, testing things. And it's a nice model, but it doesn't tell you what's going to happen in people. That's changed a little bit now because, they have these ways of defining biological age. And you see this more and more, where they can look at your certain things about your genome. And there's very characteristic things that change with age. And so if you expose the system to some agent and you can see the biological age change before you've waited years necessarily. And that's revolutionizing that field. You want to see how many people were in the study. You see a lot of studies and fantastic results, and it was 6 people. And it tells you nothing, really.
And they were very carefully chosen.
Yeah, yeah,
So,
yeah. How long did they follow up? Looking at the effects, they can say, well, it was great and there were no side effects. Well, how long did they follow these people?
Yeah.
You'd like to see, and that's what's nice about when there's research being done on something like a statin that's been around for 20 or 30 years, and you have hundreds of thousands of people, millions of people who've taken them. If you do your work, you have the data to mine. There are different types of studies also. Some studies are looking backward, and they are really basically asking histories of people and what, let's say, how much of a certain food did you eat and what happens, or have you taken vitamins? Vitamins is a good example, right? Because a lot of things have said, well, vitamins seem to be good for people. They seem healthier. And the problem there is the study population is already, it's a bias because people who take vitamins generally care about their health and are going out and buying something for their health, so they're motivated. So to say that the vitamin is it and not the other 25 things they do because they're concerned about their health, you don't know. So that's difficult to tease apart. The other thing about retrospective studies is you're relying on people's memory, which is never very good. And even with where they can ask people what their recollection is, and they also have the data, and they've looked at the discrepancy, and it's pretty wild. It's just not easy to remember these sorts of things. And then there's prospective, where you start with a theory and you take your study population and you go off, and over time you collect data and you see what's going on. And that's a more powerful study to look at. Placebo-controlled, if you don't have a placebo control group, in other words, you have a population and you're saying, I want to see what happens when we give them vitamin C. Well, if you don't have a placebo group that you're giving a pill to that's the same color, tastes the same, looks the same, people take it, you don't know, because there's this placebo effect where people, and it's pretty powerful. In order to get a medication passed, you have to be better than a placebo. And a placebo causes 1/3 of the population to get better, 1/3 of population, no change, 1/3 worse. So you have to do better than that. And often that's not so easy, to achieve. The other thing is, in the placebo group, how do they select them? Is it a good match? I mean, are they a similar population that we're comparing the exposed group to, right? And one of the best ways to do that is with randomization, so that you're not really picking. You're saying we have this population. You put into the computer, we want this age range, this demographic and everything, and it comes out. And then the last thing is it blinded? And that means, if I'm the researcher, do I know who's getting placebo and who's getting, And so if it's single blinded, that means that the people don't know, the recipients. If it's double blinded, the researchers and the people don't know. And that's what you really want, because, there are all sorts of, subtle cues and things that happen that bias the observations when you don't have it that way. Another thing that, is typical, and this comes in with the meta-analyses, is, it's selection bias. Nobody, I think, theoretically, scientists or, researchers are, unbiased, and they're interested and they're doing a study, but these studies cost a fortune. They go on for long periods of time. The researcher has an investment in an idea, almost always. And so if you're choosing, you say there's 2,000 papers on this area, and here are the criteria I use to include any of those studies. It's very difficult for researchers not to have some kind of unconscious bias where they're selecting more that agree with their hypothesis than the other. So I think you can vet a particular research study to a certain extent, but it's a lot of work and it's not very easy. And there are all sorts of statistics also. Statistics can prove anything, it seems. So it's helpful to have some go-to sources. These are three that I think are pretty reliable. I like the World Health Organization on the list because it gives you a sense of a more international thing, because there are some things that are specific to the country that you're in, like the sugar lobby in the United States affected this in a way that it was not happening the same way in Europe. The CDC is a good website. They have, a good rigorous control over, what studies you would find there. NIH also is, I think, as reliable as anything. There are also, clinics or hospitals that, have a very active research, program. And these, I think, are some of the best. They're, it's not infallible, but I think that they have really good people. They're really rigorous, and they're not owned by industry. In terms of journals, I like Nature a lot. There's Nature Medicine, Nature Endocrinology, Nature Diabetes. There's a million Nature publications, and they're all quite good. So that's a good source. The New England Journal of Medicine is sort of considered a gold standard in medical journals in this country, and I think it is good. And sometimes they have pieces that are very readable. Especially if there's something the public has become interested in, they'll have editorials and things that can summarize the situation really nicely. British Medical Journal is similar. And then Journal of the American Medical Association, JAMA, is sort of a in the trenches, good clinical, up-to-date source. So that, I don't know if there's any questions or comments about, reading health news, but it's harder than you'd imagine in terms of really being able to determine, whether a claim is reasonable or not. I mean, as you can see, I mean, for 40 years, we had this data and it somehow wasn't translated. It's hard to imagine, right? So should we just go on? Yeah. So choosing a doctor. How long have they been doing it? And this is, one of those things, you don't want them too old, you don't want them too young, you want them experience, but they're still up to date on the stuff. If somebody is affiliated with a research institute that has teaching responsibilities, they're affiliated with a residency training program, for instance, that's a better doctor to have, I think. None of these in and of themselves is in or out, but that would be somebody who's more likely to be keeping up, if they're teaching and things. I think it's fair to ask when you're interviewing them, and I think it should be sort of like an interview. I know that some doctors, that's rocking the power balance, and how dare you, but it's a big decision. You're putting yourself in their hands, and you want to have a sense that there's going to be a collaborative relationship going on, and not some. Well, we ask how long do you spend the average visit? You don't want to be in and out of there in 15 minutes. So I like to have people ask them what's the prevention treatment balance, because we live in a time where prevention, you want to have somebody who's really good at prevention. It's good to have someone who's really good at treating problems, but it would be even better if you can prevent them from ever happening. Yeah. And what we're realizing now is, if you have to track, your changes. So, if you ask somebody, you showed them a stock, and you say, I think this is terrific stock, you should buy it. Nobody would buy it without looking at, well, what's its price today? What was the year's high? What's been going on? And look at a graph of it, right? I mean, it's the same with your record. You want to have a guy who is going to have your labs, and believe it or not, this is not how it's usually organized. They'll have the last draw of blood and the results, and they might have the one before. But unless they're doing, and it's not hard, right? Their own spreadsheet with, each patient, and you can say, well, you've been with me for 5 years and your cholesterol was this, and then it was this, and then it was, so for instance, diabetes, and this is where it's related to treatment versus prevention. If your blood sugar, fasting blood sugar, is marching up a little bit every year, let's say, it was 80s, then it's 90s, coming up to, and then you come in one day for your annual and the guy says, you're diabetic. Well, that should not be a surprise. Nobody becomes a diabetic on Tuesday. You have, by the time that your blood test result, and this is true across the board, whatever the blood test result, by the time that's outside of the normal range, a lot has happened. And unless you're talking about trauma or certain specific, infectious disease, but if you're talking about metabolic disease, which is the big focus now, right? It's diabetes, weight issues, cardiovascular health. Those are things that change slowly. And we've seen now, children, we should get a baseline when they're kids, ideally, right? To know what's going on. And they've shown in autopsies of, motor vehicle accidents and things where children have plaque, some children, so you really want somebody who's into prevention, and you can tell, you can just ask that question, very matter-of-factly, and the guys who are into prevention will start talking about it because that's what they're interested in. I mean, not that they're not interested in treatment, but they see that as a major part of their work.
I recently went for blood work, and Medicare does not want to pay for the A1C.
Yeah.
In fact, I had to sign a form that if Medicare didn't pay, then I would have to pay $80 out of pocket. But I have this arrangement with my nurse practitioner. She says, if that comes up, call me and I'll put in some different codes and then it'll be covered. But isn't that ridiculous that they wouldn't want to pay for
Yeah.
that?
So what they'd like to do is not pay for that.
Yeah.
And then when you're diagnosed as diabetic, they have to pay for it.
Right.
And then they have to pay for all the other things that go along with being diabetic. I mean, it's really unfortunate. I was just talking to someone, they have these continuous blood glucose monitors now, and they're brilliant because, everybody responds to foods differently. You can't say, you could say ice cream or something, but you can't say white potatoes versus rice versus bread. People, from individual spike their blood sugar differently with different foods. And the beauty of the continuous blood glucose monitor is, number one, you don't have to prick your finger every morning to find out. And the other thing is you can see I had this meal and this is what my blood sugar did, or I had this drink and this is what and that's how you can really start making changes in the way you eat that are going to have a real impact. One size doesn't fit all with the stuff, but you can't get the insurance company to pay for a glucose monitor. This is, you can ask, what lab tests or biomarkers do you consider essential? Asking these questions, I guarantee you'll probably be one of, maybe the only person who's done. This is not standard, interaction. But if you think about it, some people say, well, no, I got them very highly. The guy's terrific. How many times have people said to you, I got the best guy in the cardiology, best guy in the world? There's no such thing as the best guy in the world, number one. And also, how do people assess who they think is good?
Yeah.
Do they have numbers on what their outcomes have been? Most people don't have that data when they're talking. It's hard to get that data, right? If you're talking about surgeons, you can get it, but if you're talking about internists, you can find out if there's been malpractice suits, but that's not. So I like to ask that question because they're going to either answer you immediately, go, why would you want to know that? Or, you wouldn't understand anything I would tell you about. I mean, I've heard all of the, you know, yeah. So it's a litmus test in a way of, are we going to be working together? And are you going to educate me or tell me this is something you should know about because that's what you would want, you know, or is it somebody who wants to be just, you know, in total control and there's no question. That's why you come to me. I'm educated and that's no good anymore.
No, it doesn't work.
No.
Doctors have a hard time transitioning. Because a lot of patients come in and they've already gone online and they've researched
Oh, yeah.
everything and they come in with, you know, should I take this drug? Should I do this? Or what? And some doctors really resent that.
Yeah.
They don't like it at all. They
I
don't-
never minded when people would ask, but I didn't like it when they said, I need to get a prescription for this drug. This is the one I know. I mean, I read about it.
But you're putting your name on that paper.
Yeah.
Sorry.
Yeah, it's hard. I mean, you want to encourage them to be reading and, you know, be interested. But often it was like, I know a guy who at work who went on this, he's doing great. Well, that doesn't mean it's going to be great for you, you know, let's figure it out. So when you ask about, you know, specific tests, so there's the ApoB. So if he doesn't mention, she doesn't mention ApoB, I would ask, what about, so what are these? These are, so you said your insurance company doesn't cover. So this
Medicare doesn't like pay
Yeah.
for an A1C.
So hemoglobin, this is hemoglobin A1C. And what it tells you is where your blood glucose lives on average over a 3-month period. So, you know, you go in, you have your blood drawn and you say, what's my fasting blood sugar? That's one point in time, right? That day. Who knows what you might have had the night before? Did you sleep well? Are you anxious? Is the cortisol high? You know, there's so many variables. So one point in time doesn't tell you a lot unless it's way off, right? But hemoglobin A1C tells you, well, this is where your average blood glucose has been for 3 months. That tells you a lot, right? For that one not to be covered is crazy. I'd rather not have the fasting, you know, just the 1 point in time. ApoB, we've talked about. That tells you right away, in very simple terms, how many particles are in your bloodstream that could be causing cardiovascular disease. The concentration of cholesterol is not going to do that. Yeah. And then CRP is C-reactive protein, which is a marker for inflammation. Now, it is a one-time, you know, cross-sectional measurement. So, and it can be bumped up if you have a cold, if you know, really slammed your knee into something, you know, a bruise. But if you consistently have CRPs that are high, and the other thing is, you know, you want to see somebody who gets a result and it's abnormal. And the first thing they do is they're not reaching for their prescription pad. We're talking to you about that. They're going, you know, you've never had this. There was no trend before. Let's repeat it. You know, before you start entertaining the idea of treating something. Yeah. But CRP is a good measure of inflammation, and inflammation is a good measure of how are you doing generally, because almost every disease process, the first chapter of the story is inflammation. When stuff starts not working right and compensatory, you know, mechanisms aren't doing the trick, the inflammation is the body's attempt to fix something. And when it doesn't work, the inflammation gets stronger. So if you see, you know, significant inflammation, that's a signal that, you know, why? But a lot of things, you know, inactivity can cause inflammation. Processed foods are really inflammatory. So there's a lot of different things, but you want to take it apart. And in terms of prevention, I would say that those three are probably the most important. There are lots of others, but they're less significant. But I would say if I was shopping for a doctor and he didn't use those, I don't think I'd want to be in his care, her care. Another thing is, so, you know, I was saying you're the most important person on the team. You want to have the records. Also, right? Because these people are busy, they're distracted, they've got, I don't know how many patients they're seeing a day. It's really helpful if you come in and you go, what was my hemoglobin A1C this time? Because I remember last time it had started to come down from the time before, or something like that, you know? And some physicians are very welcoming, you know, about, you know, sharing the records, getting the records to you. There's now, you know, a lot of places have patient portals, like Columbia Memorials. I think they're pretty good with that. So you can, as soon as the results are in, you have access to it as soon as the doctor does, right? I think that's great. And I think that you want to download those, you know, and make your, you know, Excel sheet. I think it's nice to have a sense of, you know, who is in their referral network, especially if you're talking about an internist, because that's probably going to be where you get the name for, oh, you need an orthopedist, or, oh, you need a cardiologist, or, you know, and sometimes, you know, it's just another person at that institution. But if you're seeing somebody who's not, you know, based in a hospital, you have no idea, and so you have to ask. In the same way that I think you want to ask, you know, where do they hospitalize people when they have to? That's important. Yeah. As we were suggesting earlier, you know, doctors who are involved in research or are at an academic institution or have teaching responsibilities or even a journal club, you know, they're more up to date, informed than, you know, people who are more isolated. Yeah. This is sort of going back to the health literacy, but, you know, the doctor isn't the final, you know, say. And so this can be something that you use as a reference when there doesn't seem to be an answer, or there doesn't seem to be an intervention. And so you want to know what's going on in this arena. And so you can go to these sites. Researchmatch.org is a nonprofit, NIH funds it, and it connects people with the researchers doing the studies. And it's a pretty well-designed website, and the people who are you know, doing the research want to be contacted. I mean, one of the things that I've experienced that continues to amaze me is, you know, I'll have a client and they have a very specific issue, and I'll, you know, do sort of a literature search, and then I'll identify, you know, some of the people in this country who are the leading researchers, and I'll send them an email. I almost always get, and you know, I'm nobody, I almost always get a response the same day. And it's because these guys are passionate about it, and they love getting, you know, oh, another story, you know, what was going on, and sharing their information. So that's true. I think that would be true. Not as easy if you're not in the field, but it's still an option. So, you know, these guys who, you know, you would find on the researchmatch.com, they would welcome, you know, most of the time, you know, your interaction. The other one is clinicaltrials.gov. And that's, you know, specifically, it's not just research, it's clinical trials. And that's international. The top one is mainly American. And the US National Library of Medicine provides this thing. And it's an incredible database. And it has, you know, results of studies so that you can get to see, oh, this is the condition I'm interested in. This was the treatment that I'm entertaining. What have the studies shown? You know, and boom, you've got a list of them. And it's also all human studies. So there's a lot less to toss, you know, when you're trying to interpret the results. So I think that's it.
I have a question for you. You know, so often now you don't get to see a doctor. You get a physician's assistant
Yeah,
all the time. And what I tried to do is I asked, well, can I see a doctor at least once a year? And, you know, then I don't mind seeing the physician's assistant, you know, for the Medicare checkup or whatever. But they said, no, I just have to see a physician's assistant because the doctors are too busy and they can't take any more patients, was the answer I got. And it's frustrating. I mean, I want to feel, and I think the world of the physician assistant, they go through a lot of training, I realize that. But I'd like to know that a physician is seeing my file and going through the records. I love the patient portal because I go on that and I check it.
Yeah.
Keep a look at it, but I'm disappointed that I
Yeah.
cannot see a doctor once a year.
yeah. And that is the doctor's office or the insurance company?
The doctor's office, some of my
The doctor-
insurance company is great, I have Medicare and I have United Healthcare, and never have had a problem seeing doctors before at all, it's not my insurance.
So this just started?
Pardon me?
This just started recently?
Well, I've lived up here 5 years now, and I've yet to see, other than a specialist, you know, I've had, you know, orthopedic specialist or
Yeah. No,
I
I
have
hear
a bone
that.
doctor, but
My partner just moved in here, the same thing, he's got.
yeah, I mean, you know,
He can't, like his primary is a physician's assistant.
yeah, yeah.
So they can't find a physician.
It's very disappointing.
Take the
Yeah.
patient.
It is, because I don't pay less for my insurance, you know, I'm still
Yeah.
paying top bucks for the, you know, insurance and, you know, and I finally have reached a kind of a understanding with my physician's assistant that I do my homework, and if I'm asking you a question, or if I question something, don't treat me as like an old lady that doesn't know anything. You know, I respect her intelligence, respect mine.
Yeah.
You know, and I went through a thing with her that she took me off blood pressure medicine. I've been on blood pressure medicine for years. I have a family history of stroke and heart attack and everything. And within, what was it, 2 months, 3 months, my blood pressure went skyrocket. It took me a month to get it back down, and she had to put me right back on the medicine that I had been on. You know, we went through the same thing with cholesterol, and I would love to do anything naturally.
Yeah.
But when you've been on this and when you have a family history, and so it's, I just question. So now, as I said, we have a good understanding. She doesn't treat me like, you know, I don't have any idea what I'm talking about. But, you know, I want to stay healthy. I want to be around for a lot longer.
Yeah,
And so I was very, and that's when I said, well, could I see a doctor once a year? And I was out and I told no. They'll have a doctor look at my records. Well, if he doesn't have time to see me, is he gonna have time to look at my records, you know?
And was there- yeah,
I know urgent care down where my son lives, he went there, he was very sick, and he went there, it was 4 o'clock. And they were open till 8, and he walked in and the receptionist says, oh, we're not taking any patients today. And he had to leave, and he was sick as a dog.
yeah, this is why,
They said no, I mean, how can you do that? I don't
Yeah.
understand.
I've gotten a lot of calls recently where, you know, people have come to this area, they want to get a doctor, and nobody has
No.
room.
Yeah.
Nobody's taking the
Yeah,
patients.
that's true.
So they
It's,
don't-
it's really incredible. I don't,
And I moved up from down south thinking, oh, New York, you know, the medical profession is gonna be great, and then some. You know, and
It is
it is frustrating.
Yeah.
It really, really is.
and did they give you a reason for going off the blood pressure med?
Just that I had been on it for a while, and it, you know, it seemed stable, but it was stable
On the
because I was on
medication?
medication, you know? Yeah, I mean, I was so disheartened and,
That's frustrating.
it was and it was frightening because it got really high, you know, so
Yeah,
much
sure.
so that I was looking up, you know, what When should I call yeah, the medics to
Yeah.
come and get me and stuff? But, yeah, so now I'm back on
Yeah,
what I was on before, and it's, it just, yeah, it's kind of disheartening.
it is. I mean, I was just listening to a story on NPR the other day about the number of Americans who are going bankrupt because of their medical.
Yes, I heard that too.
Oh.
So,
And a lot of them have insurance, but it runs out or it doesn't cover X, Y, and Z. Yeah,
So the question in the chat, I'm saying, is that's a positive good. A good indicator of inflation.
I'm sorry, what?
ABS. Antibodies, is that?
Can you clarify, Sandy?
Is that antibodies?
You can take yourself off mute if you want.
That would be much more specific, because antibody, right, is the immune system, and immune system is involved in inflammation for sure. But antibodies are like a key, and there's a lock, and they fit. They're very specific. So you can look at antibodies, for instance, autoantibodies, when you have autoimmune disorders, a lot of inflammation, right? And you'll see antibodies often to self. There's this, something's gone wrong, and the body is identifying itself as foreign and attacking it, so like rheumatoid arthritis or something. So antibodies can be helpful, but that's when you have very specific, and that's what's nice about the CRP. It's general. You're going to pick up if something's going on in the system. So it's good. Yeah, I mean, if you were to ask a question to the PA for the physician, is that something that is on offer?
I'm sorry.
If you were to say, could you ask the doctor this question,
Uh-huh,
would that work?
yeah,
Do they?
I actually called, and she said that they could have, I had called the office because I wanted to see if I could get switched after I went through this ordeal. And that's when I got back and she said, no, there's no doctor that can see you, but we can have him look at your record, look at your thing. So you could have somebody check on it, and stuff, but it's not the same as, is he gonna get back to you? If he's so busy that he can't see you, is he gonna get back to you? It's,
See, my patient portal, I don't know what one you belong to.
yeah, I have the patient, and I love the patient portal.
But what practice do you go to?
I go to Berkshire Medical.
Oh, okay. In the portal, you can actually put in a question
Yeah.
and send it to the doctor. I've done
If
that.
you, if that's if you have a doctor to send it, to, right?
Well, all of that, but everybody's supposed to be supervised by the doctor.
But they don't say that.
Well, I can,
Yeah.
on the drop down, I can address my question directly to the doctor.
And does the doctor respond?
Yeah.
And that's who sees you, or do you
No.
get seen by a PA?
Usually I'm seen by his nurse practitioner,
Yeah.
but he has answered my questions directly.
Yeah. And when he answers, does he sign it?
Well, yeah, it says.
Okay. Well,
Huh.
I would try that. I mean,
Yeah, they do have that. I mean, I have
Yeah.
seen, do have a list of the doctors.
Well, I'm
and
just saying
everything
that
like
Dr. Poplar always used to answer my questions. Of
Uh-huh.
course, now he's retired, he's gone, so
Yeah,
I don't know what the situation is now, but he always answers.
yeah,
yeah,
it's sort of remarkable when you look at the per capita health spending in this country. I mean, we spend more per person on health than any other country in the world,
Yes.
and we're not even in the top 10 in terms of health statistics. And I think the reason is so obvious. It's because it's capitalism. It's a
Yeah.
money-making. You can't have a money-making
That's what's happening. Yes.
endeavor. And now you just have people come in. So the doctors didn't police themselves, and so the insurance companies became powerful. That's just doubling the paperwork and the number of people that's having to get paid, right?
Yeah.
It makes no sense, and I don't know what it's going to take, but I think the public also, seems to still have an aversion. I mean, if you say socialized medicine, most people like, I don't want socialized medicine. I go, why?
Yeah,
I
don't understand.
Well, we just hear the horror stories. Of
right.
long waiting lists and waiting, a year to get a hip replacement or something.
Yeah. That story,
Yeah.
I mean.
We have waiting lists to see a doctor.
Yeah.
But yeah, no, it has its problems, but in my experience abroad. it's been-
Also, I found over there, I had vertigo that would not resolve. And I kept going back to the nurse practitioner and she wasn't helpful. And finally she said to me, you have to see Dr. Putnam. And then he sent me to a neurologist.
Because that purpose show when my son has that.
Right. And then they did a brain scan to see if I had a brain tumor, which I didn't have. But it took 8 weeks for that to go away. It was just
Wow.
awful.
Yeah, it's all.
awful.
So, that's a typical American medicine. You go to the provider, they try to work you up, it doesn't work. You get to see the doctor. He's not sure, he sends you to a neurologist. The neurologist works you up, says, well, I don't know, but why don't we get a CT of the head, right? In Europe, you wouldn't get a CT of the head unless there was some specific finding. I mean, it's the opposite end of the thing. We are like fast and loose with these tests that are really expensive and often don't necessarily add to the information. So
Sandy has another question about the HbA1c test, the same as the
hemoglobin A1C, yeah,
HbA1c test.
it is, yeah, same.
Great, thank you. I'm sitting here trying to figure out if I've ever been tested for any of the things that you are suggesting and getting conflicts. Thank you.
Yeah,
So I recently moved up here full time
okay.
and was considering changing doctors to be local. I'm a little discouraged about all this conversation. Do you have any recommendations about what to do other than just ask people who use?
I would start there. You can tell a lot about what interaction with the doctor's office will be like from speaking to people. It may be harder to tell, what's their, how good are they in terms of their, knowledge base and things. I think it's probably, where are you moving from?
New York City.
Yeah. So I would hold on to specialists in New York City and try to have somebody who's, you're an internist here and maybe not give up your internist in the city until, you see that you're, in comfortable hands. But, I remember, in internship, you have all these people wandering around going, oh my God, I thought it was 0.5 and it's 0.0, you're on the learning curve and everything. But what you get really good at pretty quickly is something serious. There's something wrong here. There's something really needs to be dug into. And that's, in a way, all you need. You just need somebody who's going to get the ball rolling of saying, you know what, you need to be seen by a neurologist, or, we need to do this test. They don't need to be one of 10 people on the who's who of, that disorder. But
You want somebody who's going to recognize when it's out of their expertise.
yeah,
And send you to the other person.
yeah. And you could even ask that if it's a PA or a nurse practitioner, what is the protocol generally when you see something that stumps you? Nobody likes being asked that question.
No.
But I'm always leery of people who say either that doesn't happen or aren't willing to say I don't know in front of a patient or say, but I'll find out. We'll try to find out. So I would hold on to specialists if you have them in the city.
It's interesting that I'm also new to the area and I would love to interview a doctor. However, my insurance doesn't cover that. Basically, I have to pay out of pocket, so I guess I have to pretend I'm sick. To a doctor and see, how he reacts, he or she. Do you have any advice for that?
Good diagnosis. You could, well, your insurance probably only covers one annual year.
Yes,
Yeah,
correct.
preventive care. And if you've used that up,
How do you know if you're going to like the person that you're making your annual with? I mean, that is a huge step.
yeah,
I don't know.
yeah. Well, it's helpful to talk to people, but it's like, when you say to someone, have you eaten anywhere good lately? And they go, oh, great. And what you always want to do is find a place that both eaten at that you would agree that, because you have no idea what they like. And so there's a little bit of that going on with the doctor, right? But I wonder, if you just have a cold or something, and you go in. I mean, the fact that we can have those many, what's it called, on Fairview, these doc in a box kind of, yeah, I mean, that's a symptom, right, of a system that isn't working.
What is it?
It's,
You mean like health grades? Is that what you're talking about?
is that what it's called? Health
Where you
grades?
score, people can score.
No,
doctor-
no, it's just, it's a drive-in. You can walk in.
Oh,
and
they're
they
urgent
see
care,
you,
urgent
and
care.
there's a, there's,
The urgent care.
Yeah.
Urgent care.
but not the ER.
Right.
Yeah.
Okay, urgent care.
Yeah. I mean, the fact that those exist means that, people don't have a connection to the healthcare system. There's no way you're going to be able to do prevention, right? Because the only time those people are going to get seen is when they're sick and urgent. Yeah, and they don't do follow-up. So it all comes back again and again and again, it seems to, there's a huge responsibility on the part of the individual to try and do it. And it's imperfect, it's not easy.
Well, I went to a urologist that I didn't like. And he wanted to do a follow-up and I called him and I said, I refuse to see him. I won't see him. She said, well, if you want to go see somebody else, you're gonna have to wait. And I said, well, I'll wait because it's not any kind of an emergency. But I've told all my friends, don't go to him. Because he's one of those doctors where I'm sitting there trying to have a conversation with him and he's poo-pooing everything I'm saying, like, I don't know anything. And I happen to know a lot about what I was talking about. And so I just found the whole get together offensive. I left actually angry.
Yeah.
And I wouldn't go back to him. Now they're doing a big PR campaign for him with a big billboard. We welcome him because he just moved from California. And I was probably one of his first patients. And so now they're doing a big PR campaign because word has gotten around that. But he's not a very nice person.
Yeah. They have health, you mentioned health grades, right? Yeah.
I use them.
It's tricky though, right? I mean, because not everybody, like with the restaurants, not everybody writes review.
Right.
There's a certain type that, either writes a scathing review or a great review. And then you have most of the population somewhere in between. And so I think it's hard. But I think if you see several people saying, I don't think they were listening to me at all, or they were condescending, that's a red flag. It's just that there's
Well,
not a
when
lot
the
of choice.
receptionist gave me this appointment, it was a red flag. Wow, you're gonna have to see Dr. Litvin. Like, even the receptionist said, I'm sorry, you're gonna have to see Dr. Litvin. And I said, okay, I'll take him. I don't know anything about him. And then I found out later that he's offending a lot of people.
Yeah. Well, so in my work, one of the things I do a lot of is finding doctors for people, right? And it's become harder and harder to do, in large part because the good docs are full.
Yeah.
But one of the things I used to do, typically, referrals are, you ask a doctor for a referral, it's the last guy you saw on the wall in the hospital or something, it's what's accessible. It's like the availability cures.
My mother was a nurse. She always made Yeah, she said, oh, it's just like the old boy network, they refer to their friends, don't pay any attention. to
Yeah.
the referrals because they're
Yeah.
not based on, who's good or not.
So
They're
what
based
I,
on who they know.
Yeah.
And-
but I think, you can get around that. One of the things I started doing was, if the client was in Boston or in New York City, let's say, I'd call San Francisco, a guy who was expert in this problem. I'd say, could you tell me, I have a family member with this problem in New York City, who would you send a family member to? And, you can get, so it's not somebody who's in their group practice. It's not someone that they just saw. And so it's not perfect, but you can get, I think, sometimes some good recommendations that way. And, you make a good point, sometimes, you can ask the staff,
Receptionist.
you know?
She was like almost apologizing. I have to give you Dr. Whitfield. Okay, I mean, I gave him a shot.
But if you smell that, I think it'd be reasonable to go, should I try someone else?
Yeah.
That's a really bad start.
Yeah, that is it is bad.
And of course, so much of medicine is, sort of an art where, this person is hopefully, going to be able to trigger all the placebo stuff in addition to the concrete right intervention.
Are they teaching medical students that, so much of it is a rapport, establishing a rapport with the
I
patient?
think more than before.
I hope so.
Yeah.
because We're more informed now. We
Well,
walk
there was
in
no need for
informed.
dialogue.
Yeah.
When I was in training, you'd ask questions for answers, and then, you'd have these old guys who used to do house calls. And, they blow you away with some of the cases they described because they saw where the person lived, they saw who they lived with, they saw the food around the house or whatever. I mean, and they just had so much more information and they were, listening for it. Now we reach for, all these tests that, immediately, and you're a series of numbers more than you are someone who lives in the situation. And that's another thing, people move around so much, nobody lives where they started out, I mean, in the old days, they knew you, they knew your father and mother and,
I knew you. family history.
They used to come to the house. I remember when I was a little girl, the doctor would come to the house.
yeah.
yeah,
He had a doctor, same doctor, all those years.
Mhm.
And he did everything. Yeah.
And he probably gave birth to you.
Yeah.
yeah,
Probably
yeah,
helped you with,
yeah.
That was the-
So there isn't any other things you want to talk about. Does anyone have any ideas about what you'd really like to hear a talk on that we didn't touch?
Oh, something else.
Ideas for if we do more of this, what topics you'd be interested in covering?
I thought the topics that you did the last time with food and even expounding on some of the different food habits and everything, because I think, that's such an important part of life now. And if you can stay away from having to go to the doctors too
Yeah.
often by how you act and exercise. And I had a friend just recently recommend this exercise. Well, she lives in Charlotte, so they do have facilities that have a lot of different exercise classes. And it's called Foundation Exercise.
Yeah,
And she said it's very basic, but she said she has some back issues and everything and does go to a chiropractor. And her chiropractor said since she's been doing this foundation exercise, he's seen a huge improvement.
yeah,
And I did send for the book, it's an Eric Goodman, I don't know if he's a doctor or not, but to find out, to read more about
Yeah.
it, and I was looking for a video, but just different things that as you get older, different things that are better to do than others, because some of the things we did in our 20s, would not be a good thing right now
yeah,
and stuff, so, but just things like that, because I found last time's, really good and
Okay.
helpful.
Yeah.
How about herbal medicines? Because I see a lot of that coming up.
yeah, okay.
Sandy suggests women's health
Okay. Yeah. I mean, the good news is we're incredibly resilient, you know, and no matter what age and what condition, if you start treating the body well or the self well, it responds. I mean, the studies looking at people in their 80s and 90s who start an exercise program, they're building muscle. They're becoming, you know, more capable of all the activities of daily living. You know, I mean, the body loves to move. It hates being sedentary. Yeah. Small interventions can have huge effects.
What do you think of, I know you recommended the protein
Yeah,
powder. Do you use that full scoop?
yeah.
That's a lot. Oh, my goodness.
Well, what are you putting it in? What are you
But
putting it in?
I put it in, I made like, but first I put it in the coffee,
Okay.
but then I had to put it in the blender because there was
Yeah.
so much in the
Yeah.
coffee. And then I tried it in, putting it in milk with a banana and everything.
Yeah.
And then but the second time I used like half the scoop instead of the full scoop, because I figured, well, I do start with that and then move on. But I wanted to ask about, I have osteoporosis and I'm on polio
Okay.
shot for that. And I was wondering, I've read a lot about collagen, and they have collagen powders also, about, they say that can help build bone mass as well. Do you think that's, and I did check with the endocrinologist, and he said I could take the collagen. I didn't want to take something
Yeah.
that might not interact well with the polio. And so I just wanted your feeling on that. Is that worth it to do that, or?
You know, I'm not sure it is worth it. Everything I've read about it, now it's been maybe 6 months since I looked at that, so I don't know what's happened since, but there's not really good data
Okay.
that it seems to help. You know, some of these things are just murky, like the what's it called, glucosamine. You know, some people seem to get some relief from that for, you know, joint problems. A lot of people don't. You know, there hasn't been a good proof of concept on that. So, and, you know, you start taking, you know, 3-4 things every day, it's expensive.
Yeah.
It can be expensive, yeah.
Yeah. Okay.
But just going back a second, if you have at least a cup of liquid, whether it's coffee or milk or something, and you put that into your blender and you put a full scoop, that should be, I mean, it might be a little thick, but it shouldn't be.
Now, would almond milk be better to do it with than the regular milk, or?
If you like almond milk, that's fine.
Because I found it gave my stomach maybe a little constipated.
Yeah, some people have a GI response
do.
in either direction.
Yeah.
And that's usually, you can usually get around that if you start with a little bit then. Go back and use a third of it,
Okay.
you know, and do that for a week, or at least until you see if you can tolerate it that way,
Okay.
and then slowly add and let your body get used to it.
Okay, cool.
Well, what do you think about vitamins? I'm thinking, I take zinc, and I take vitamin D. Doctor recommended, and certain vitamins C. And I know some doctors believe in them, some doctors don't.
Yeah.
but
I'm very selective about it. I'm not a big believer in vitamins generally. But I think that vitamin D for sure. I mean, we just don't live outside in the sunlight nearly enough. I think that C is good, but not a lot. I mean, like 500 milligrams, I think, a day. Interestingly, you know, vitamin C, there's a great story. You know, we used to make vitamin C in our bodies, and most animals do. And then, I mean, this is crazy archaeological stuff, but when the, you know, asteroid hit the planet and, you know, wiped out the dinosaurs, and there was winter and we lost the capacity to make vitamin D, and they think the reason is because one of the ways that we would really fatten up before winter was by eating fruits. And the vitamin C in fruits prevented uric acid from, being, you metabolize the fruit and you make uric acid. And the uric acid is this oxidative insult, right? And it affects the mitochondria in a way so that they stop producing energy and just shunt things into fat. And so you would hold on to fat. And that was adaptive because that's who survived, And if you had the vitamin C on board, it prevented the oxidative insult, and you didn't have that benefit. And so they've looked at, fructose is one of the major pathways to obesity or, fat storage. And if you look at what triggers fat storage through that fructose route, it's a lot of salt, believe it or not, because what happens is there's certain stressor situations that the body sort of responds to, thinking we're in a difficult situation, we need to store fat, okay, as an energy source. And one of those is dehydration. And you may not be dehydrated, but if you take in a lot of salt, the salt concentration in your blood is higher. It looks like dehydration to the body. And so it starts storing fat. So these salt licks that deers love?
Oh, yeah.
That's why. I mean, because they store more fat when they have a salt lick. But the funny thing is, if you look at all the things that we're really drawn to, salt, right? Sugar, high sugar fat storage, umami, glutamate, that really rich, meaty flavor, right? All of those things can trigger fat storage. So, if there's something that we as a species really like, it's probably something that is adaptive in a bad situation. When you're in a situation where you've got plenty of calories coming in and, it's a disaster because you blow up. I don't remember why. I always have to get that story.
How about something like honey instead of, like if you want to put honey in your tea or something, as opposed, it's still sugar?
Yeah, it's fructose.
Yeah.
I mean, having, this idea of, 12 servings of vegetables, I don't know what is there. It's like, wow, 12 servings of anything in a day is hard to imagine. But the fruit thing is like 4 or 6 or something. I don't think so. I would not have so much fruit, especially because the fruit we eat now also is just bred to be so sweet. That's what makes it tasty. And making it in a drink, like the banana. I wasn't going to say anything, but I might not put a banana. Eating a banana is okay, but you don't want to drink your calories. So to get the protein in, it's almost impossible to keep up if you don't have a protein supplement drink. But the other stuff, you don't want to drink calories because you absorb them faster. You don't get the same satiety response that you're full. Yeah, that's what I mean. Juice. It should have like a red circle with a line through it. I mean, it's been labeled as this health drink. Good breakfast, nice big glass of orange juice. No, it's basically a glucose tolerance test. Yeah. All right. Thank you.
That's great. That's
Yeah.
really great.
Pleasure.
See you soon on the next ones.
Yeah.
Yeah.